Good afternoon, everyone. Let's get started. Welcome to the clinical workshop on tumor-agnostic approaches to care. My name is Sangeetha Reddy, an assistant professor at University of Texas Southwestern Medical Center, and I'll be moderating the session for you today. Today, you'll be hearing from 4 speakers covering varying modalities of tumor-agnostic approaches, including targeted therapy, antibody-drug conjugates, and immunotherapy. Just so you know, given the limited time frame we have, we'll wait till the end to field questions for all the speakers. Our first presenter is Dr. Vivek Subbiah, Chief of Early Phase Drug Development at Sarah Cannon Research Institute. He'll be giving an overview of agnostic trials in the field of targeted therapies. Dr. Subbiah.
Thank you so much for the warm introduction, Dr. Reddy, everyone. She was our fellow. She was our fellow at MD Anderson, and look at where she is, introducing all the speakers. Great, please hand to her. Mom of 2 beautiful girls, all right? So I still remember the baby. All right, it fills my heart with joy unspeakable to talk to you all in my first San Antonio breast cancer meeting, tumor-agnostic drug development. I personally believe that estrogen receptor, right, is tumor-agnostic. Let's talk about that later, maybe in the next year when you invite me again for the tumor-agnostic session. All right, so these are my full disclosures from June 1st, 2023. I recently moved to a new institution. In the brief agenda for today, I'll be talking about current state of drug development and precision medicine, tissue-agnostic drug development, also the current tissue-agnostic FDA-approved therapies. So how did we treat patients with metastatic cancer before the next-gen sequencing era? It was a pure palmistry crystal ball approach. Oncologists, we compare ourselves to astronomers, right? We want to go to the moonshot program. So if you see that, these are the Jupiter's moons, as you can see from Galileo's telescope. So my 9-year-old is very interested in astronomy. So we went to Sedona, we bought a microscope, the telescope from Amazon, and this is how the Jupiter's moons look. Right now, we moved on to the James Webb telescope. You can see the telescope's first public image showing a cluster of galaxies. Cluster of galaxies. So with the James Webb telescope, we are able to see 13.5 billion light years into the universe. 13.5 billion light years. I cannot wrap around my head of one light year. 13.5 billion light years. So Galileo's telescope to James Webb telescope. In oncology, we've evolved from the light microscope to the molecular microscope. So what is a molecular microscope? Molecular microscope is essentially next-gen sequencing. This has been enabled by Moore's law. What is Moore's law? 30 years ago, they said we cannot sequence a human genome. It took $3 billion to sequence the first genome. Right now, we can get the genome sequence for $1,000. Colleagues in India and China can do it for $50. A colleague in Singapore and a colleague in Mumbai has promised that genomics can be done for $1 in the next decade. So every patient is going to get genomically tested in a clinic near you in the decade. So we have to be ready to be an oncogenomic savvy workforce. So Moore's law is that the cost per raw megabase of DNA sequence comes down. In oncology, we have the opposite of Moore's law. We call it the Erum's law. Discovering new medicines becomes more and more expensive. 30 years ago, it cost $1 billion to make 30 drugs, whereas now it costs $1 billion to make 1 drug. I don't know why the slide keeps jumping around. Must be the timing, but I'll try to adjust. So how we break Erum's law, how we break this cycle of rapid slide moving, right, like this, right? Advent of next-gen sequencing, biomarker-driven drug development, repurposing drugs, and tissue-agnostic drug development. So what is tissue-agnostic drug development? All right, so as a field, we are used to be developing drugs for breast cancer, kidney cancer, prostate cancer, etc. Tumor-agnostic era is a different way we think about oncology. Again, these are the current precision medicines approved in oncology, right? This slide is old, because after this, we have 10 different precision medicines being approved. Tumor-agnostic drug is a drug that targets any kind of cancer, regardless of where it originated in the body. A tumor-agnostic treatment treats any kind of cancer as long as the cancer harbors the underlying molecular alteration. As of December 5th, 2023, we have 6 different tissue-agnostic medicines approved for 7 different indications. So we've entered the new era of tissue-agnostic approval. May 23rd, 2017, this represented a watershed moment when we had a marriage of genomics and immunotherapy. Why do I say it's a marriage? Because pembrolizumab was approved in a histology-independent fashion. For the first time, a treatment was approved in a biomarker-dependent manner, not based on histology. It was a tumor-agnostic approval. Approval was based on a genomic biomarker. Approval was based on a single-arm study, and approval was based on retrospective and real-world data. As you can see here, this is a pan-tumor MSI assessment showing a prevalence of 16.15% in endometrial cancer to as low as less than 1% in soft tissue sarcoma. The response rates varies across tumor types. Endometrial cancer, 57.1% to brain tumor, where it doesn't work. The next is the story of picking needles in haystacks. 2 drugs, larotrectinib and entrectinib, were approved in an age-agnostic, histology-agnostic manner in all NTRK fusion adult and pediatric solid tumors. NTRK fusions are drivers across diverse cancers. As you can see here, it's a driver in rare types of breast cancer like mammary analog secretory carcinoma, secretory breast cancer. Again, in pediatric cancers, tough to treat cancers like pontine glioma, anaplastic thyroid cancer. Again, if you see that it's an estimated 1,500 to 5,000 patients a year in the US alone, right? And these drugs confer a high response rate. Although these are picking needles in haystacks, think about it. These are phenomenal drugs. I have patients whom these drugs are working for more than 5 years. So a rare disease like 5,000 patients a year can become a common disease because these patients, first year it's 5,000, second year it's 10,000, third year it's 15,000, so on and so forth. This is the data for larotrectinib in NTRK fusion positive solid tumors. The response rate is 57% as of the latest data set. Again, works regardless of histology. Same thing with entrectinib, works regardless of histology, regardless of NTRK fusion partner, regardless of line of therapy, regardless of age. Again, the marriage of genomics and immunotherapy story continues. Pembrolizumab was once again approved in a histology-agnostic manner for high tumor mutation burden cancers. Next, we have 2 new kids on the block, belzutifan for VHL-positive tumors and dabrafenib and tremetinib for adult and pediatric BRAF V600 positive tumors. Again, BRAF V600E is seen across multiple tumor types. Again, in hairy cell leukemia, it's universal. Today, we have a histology-agnostic approval of BRAF based on the pooled analysis of 3 studies. One is the Roar basket study, as you can see here, and the next is the NCI match study and pediatric studies. Clearly, you can see here, BRAF is a histology-agnostic, tissue-agnostic target. Cancers like anaplastic thyroid cancer, cancers like difficult-to-treat cancers like glioblastoma, right, high-grade glioma, 33% response rates. Maybe with the exception of colorectal cancer. However, in colorectal cancer, we see responses with the addition of EGFR inhibitor. You can clearly see that dabrafenib and tremetinib BRAF-MEK combination is clearly a tissue-agnostic target, both in adult and pediatric cancer types. The next target is RET. Alterations in RET structure and functioning can lead to tumorigenesis. RET is activated by 2 major mechanisms in cancer. One is RET fusion, and the other is RET mutation. RET fusions are seen in 1 to 2% of non-small cell lung cancer. And beyond lung cancer, they are seen less than 1% across tumor types, including pancreatic cancer, colorectal cancer, among others. RET mutations are oncogenic events in sporadic medullary thyroid cancer and universally among all hereditary MEN2A syndrome cancers. Again, this is the data. These are the waterfall plots showing tumor shrinkage, showing selpercatinib, a selective RET inhibitor, showing tissue-agnostic activity. This is the latest kid on the block, September 21st, 2022. Again, as you can see there, the waterfall plot, that patient with pancreatic cancer, every waterfall plot, a histogram, has a patient behind it. This is a patient with RET fusion positive pancreatic cancer who was exhausted of all standard lines of treatment. And when she showed up in our phase 1 clinic, her performance status was rapidly declining with ascites. And we did sequencing, we found RET fusion. And we started her on selpercatinib, and then she had an amazing response. In fact, when she showed up to our clinic, she said, I want to start the trial in 2 to 3 weeks later. Why? I said, she's going to get married in 2 weeks. I said, no, you start trial tomorrow. I'm sure you're going to be okay. So she was wheelchair-bound with ascites. On her wedding, 2 weeks later, ascites vanished. She could walk. She danced in her wedding. She threw out her wig. Again, these are the stories that keep an early phase investigator up in the morning. This, my friends and colleagues, brothers and sisters, is like needle in a haystack. We can confer every patient the gift of time. Always, oncologists love 2 drugs. This is the second drug showing pan-cancer activity. Again, showing that RET is a tissue-agnostic target. So we have BRAF, RET, and NTRK as biomarkers for targeted therapy. I'm not going to be talking about trastuzumab deruxtecan. Hopefully, that will be approved in a histology-independent manner. So right now, what you see here, there is a theme. When we have the right patient with the right target, with the right drug, with clear benefit, there is a pathway for FDA approval here. So what's next? So this is Relay 4008, which is lirafrugatinib. There's going to be a spelling bee after the meeting for all the oncology, small molecules and monoclonal antibodies, right? So in patients with heavily treated, because it's a breast cancer meeting, I wanted to show the breast cancer data. This is a tissue-agnostic drug. The data was presented in the triple meeting, but this is the data showing that out of 14 patients, 10 patients with breast cancer were shown, and 70% of them with ESR mutations, and 70% of them had tumor shrinkage. Again, this is emerging as a tissue-agnostic drug or tissue-agnostic target as next. NRG fusions are the next tissue-agnostic targets. Clearly, you can see that NRG fusions are actionable across multiple tumor types, including breast cancer. KRAS G12C, again, a tissue-agnostic target. So you see the theme here. We are moving from the current paradigm of one-size-fits-all to customizing and personalizing precision therapies to the right patient at the right time. These have been enabled by evolution of clinical trial designs in oncology, what we call it the basket studies, umbrella study, platform study, and the master observational studies. So I asked ChatGPT to help me come up with a poem. What's a future of tissue-agnostic precision oncology? ChatGPT in Shakespearean style. In future's light, a beacon bright shall gleam, tissue-agnostic medicine's bold dream, no more confined to the cells of one cruel name, but tailored cues each patient's path to claim. With science's word and data's steadfast hand, we'll conquer cancers as we understand. The intricate dance of genes, that was my line. My contribution to ChatGPT, a mystery, unlocking healing's boundless tapestry. What's the message? To ensure that every patient with solid tumor could benefit from histology-agnostic therapies, it will be essential to identify these biomarkers by comprehensive genomic testing. We cannot guess which patient has NTRK fusions. We cannot guess which patient has TMB alterations. We need to do NGS. So, SABCS unites minds advancing precision, tissue-agnostic breakthroughs, and medical vision. Thanks to patients and all the caregivers for their participation in all the clinical trials. Available on Twitter, and happy to answer any questions after the session. Thank you so much.
Thank you, Dr. Subbiah, for that whirlwind tour of the recent and emerging updates in targeted therapy and a little bit of astronomy and ChatGPT on the side. Next, we have Dr. Joshua Drago from Memorial Sloan Kettering Cancer Center, assistant professor, to discuss antibody-drug conjugates across cancer types. Dr. Drago?
Hello, everybody. Thank you so much. It's a pleasure to be here. So I'm here today to talk about ADC development across tumor types, and today I want to focus on target measurement and modulation. These are my disclosures. So the central question that I want to focus on today is what lessons can we learn from ADC development beyond breast cancer? What type of advancements are occurring in other tumors that we might be able to apply indirectly or directly to help our patients with breast cancer improve outcomes. So stepping back, ADCs are being very rapidly developed for cancer therapy. The first ADC was approved back in the year 2000. There are now over a dozen that are approved by the FDA. More than half of those were approved since the year 2020. And we've had some major successes in breast cancer, but we're not alone. There's a lot of interesting development going on beyond breast cancer. Sometimes we can get siloed as oncologists into our own subspecialty field, so it's always important to look beyond that to see what kind of take-homes we can learn from and really use to inspire care of our own cancers. So the two lessons I really want to focus on today: one, looking beyond conventional immunohistochemistry-based target measurements will uncover better rational biomarkers for antibody-drug conjugates, and second, the combination ADC-based treatment protocols have untapped potential. So antibody-drug conjugates are modular entities. They're composed of an antibody, a linker, and a payload. Here I have TDM1 on the left and TDXD on the right. These both target HER2, a kind of canonical cancer target in general, but more specifically a target for ADCs. These will be kind of the center point of the examples that I use today. And I want to discuss two specific examples from outside breast cancer. They're both kind of stemming from homegrown science from the MSKCC ADC Translational Group. One is fully realized as an FDA-approved therapy indication that's from lung cancer. And the second one is a preclinical study that's yet unpublished, but hopefully will be investigated imminently in patients, and that's from colon cancer. So I don't need to belabor this point, but immunohistochemistry is a really imperfect biomarker for ADCs. It's assay dependent. It was designed to identify dramatic overexpression. It's hard to grade low or intermediate expression levels of proteins, and pathologists disagree really widely in assigning expression levels to IHC measured proteins. And when we look at how this plays out clinically, prospectively, even when you control for pathologist reading by doing nicely controlled pretreatment samples, central review of pathologists, you still get discrepancies between protein expression as measured by immunohistochemistry and response. So on the left, you see in the DAISY trial, patients with HER2 low cancer that have expression of the target. Several of them have de novo resistance. There were also patients in the absence of the target according to IHC who had responses. And the same thing was observed in the ASCENT trial with sacituzumab. On the left, patients, again, lack of response in the presence of the biomarker, and then response in the absence of the biomarker. So there's some work to do here. How can we improve our biomarker design? Biomarkers, in my view, should be quantitative, replicable, and reliable. And they should also be rational in that they acknowledge and they incorporate our understanding of the mechanism of the action of the drug that they're designed to predict benefit from. We have a very good example of such a biomarker in breast cancer, which is the Oncotype score. It's quantitative, it's reproducible, and when you kind of open up the hood and look beneath, it has components that are really designed and focused to predict benefit from one, chemotherapy, and also sensitivity to endocrine therapy. So there's RNA-based sequences for cell proliferation and invasion, for endocrine pathway activation. Those are kind of compiled together to give you a numerical output that really helps us with counseling our patients. So when we think about biomarkers mechanistically, how can we apply that to ADCs? We know that most ADCs need to be internalized for maximal effect. So they find the marker at the surface of the cancer cell, they're internalized by the endolysosomal pathway. There, the linker is cleaved and the payloads are released. This is how they kind of have the maximum cytotoxicity. Interestingly, HER2 as a surface protein is not internalized very quickly. It's internalized relatively slowly. But several researchers at MSK a few years ago had a very interesting observation, which is that compared to wild-type protein, mutant HER2 is internalized very rapidly. So specifically, HER2 that has activating mutations in the kinase domain, it's constitutively activated, and it's rapidly cycled on the cell surface, internalizing really quickly. So the hypothesis came along, what if we could use that as a docking station to internalize ADC and deliver a high amount of ADC and thus the payload into cancer cells? And indeed, it looks like this is the case. So on the left, you're looking at a lung cancer model. The kind of fluorescence you see is actually TDM1 that's labeled. So once it makes it into the cancer cell, it lights up. You can see that compared to wild-type HER2, the lung cancer cell lines that harbor a HER2 mutation internalize more ADC, and that's represented graphically in the middle. On the right, you see a PDX model with really profound sensitivity to TDM1 in the setting of an activating HER2 mutation. So this was rapidly translated into a prospective clinical trial in lung cancer with the drug TDXD, Destiny Lung 01. So we see here that TDXD has pretty impressive activity in a HER2 mutant advanced non-small lung cancer. One thing that we notice is there's not a lot of de novo resistance here. Another thing is that if you look along the rows on the bottom, you'll see that many patients actually had responses even with HER2 immunohistochemistry scores of 0. So kind of absence of detectable HER2, but even what little HER2 was there was internalizing so rapidly, it's enough to internalize ADC to achieve a cytotoxic effect. So we're starting to kind of get this interesting story where you have static expression, but also dynamics, right? Internalization. In some cases, you need high levels of static expression to get enough drug into the cells. But if you're internalizing really quickly, you're able to do that even in very, very low protein settings. So I think this is an example of a very rational mechanism-driven biomarker for antibody-drug conjugates from the lung cancer world. We've already started to investigate this in breast cancer. So this is Destiny Pan-Tumor 01 presented just at ESMO this year. And you could see, again, decent response rate in patients with metastatic breast cancers. And again, patients in the absence of HER2 expression or HER2 amplification are still having responses to this drug. So ERBB2 mutations are uncommon in breast cancer, between 1% and 3%, depending on the study that you look at. They're actually a little more common in lobular breast cancer, which is an unmet need, in my opinion, which is great. So I'm very excited about this possibility. But what can we do about patients with target expression but without mutations? This is a multiplex immunofluorescence panel that we designed specifically with the goal of being a multiplex biomarker for antibody-drug conjugates. You could see HER2 in green. We have other markers like Ki67 in yellow. You see divided cells. So you can really get a rich picture of the tumor as well as the tumor microenvironment from tools like this. And importantly, they're analyzed in a way that doesn't necessarily require human pathologists. So you can feed these into computational pathology platforms that can determine tumor from stroma and ultimately assign cell-specific values to specific markers, okay? And you can get very reproducible quantitative output. The downside of this test, though, they're time-consuming and they're also relatively expensive. So I had the pleasure of collaborating with AstraZeneca on alternative tools to measure basically HER2 staining on archival IHC slides. The premise here is that immunohistochemistry slides actually do contain a lot of information, but it's in the post-analytical variation by the pathologist where you start to lose some of that. So if you feed archival IHC slides to a computational pathology platform, you can actually get very nice cell-by-cell quantitative outputs for marker expression that correlate very nicely with pathologist rating on the left, as well as with immunofluorescence on the right. And you can even go beyond that and measure heterogeneity. So using this same tool, you're able to see not only how many cells in a given tissue sample are HER2 positive, but also the percentage of HER2 negative cells that are within a particular radius of HER2 positive cells. And this has clear relevance to the bystander effect, right? A major way that we think ADCs are active in cells that have lower heterogeneous tissue biomarker expression. So we can kind of functionalize these assays to even quantify susceptibility to the bystander effect from ADCs. So ongoing questions from this kind of first example is targeted internalization as important as target expression for ADC activity? And second, can we find other ways besides activating mutations to capture ADC target dynamics in a biomarker? Next, can target dynamics be modulated to augment ADC activity? This takes us to our second example in colon cancer. So we know that response to T-DXd differs dramatically across tumor types despite similar target expression. On the left, you have response rate in HER2-positive colorectal cancer of about 45% compared to the right, nearly 80% in HER2-positive breast cancer. On the bottom, if you kind of look across the row, you see responses 80%, 70% in endometrial cancer, but virtually no responses in pancreatic cancer, despite 3+ expression across those tumor types. So is it possible that differential sensitivity to the ADC payload is responsible for this? It is, but I want to venture that there's an alternative hypothesis which might be in play as well, which is that differential target dynamics could explain some of this variation. And interestingly, a lot of the tumors that are more rich in EGFR expression tend to be worse responders to T-DXd. So that led to this hypothesis. Could actually the dimerization partner of HER2, the ADC target, affect internalization rates and sensitivity to ADCs? So we know that HER2 surface dynamics depend on the dimerization partner, and interestingly, EGFR HER2 heterodimers are highly stable on the cell surface. They do not internalize rapidly. This is a colon cancer line. If you overexpress EGFR, you find you tilt the scales towards more heterodimers, EGFR HER2 heterodimers over homodimers. One would hypothesize that that would slow the internalization and delivery of ADC, and that's exactly what we see. So on the left, you have two lines. When you overexpress EGFR, you decrease internalization of T-DXd into the cancer cells. And you see that play out in preclinical models, where T-DXd in and of itself is very effective, but if you overexpress EGFR, you lose some efficacy. And we think this is probably not due to a trophic effect of EGFR, but actually due to changes in surface receptor dynamics. So that leads to the question, can combination therapies increase ADC delivery? Indeed, it looks like they can. So here's preclinical evidence using cetuximab, an EGFR-targeted monoclonal antibody that can help to overcome the decreased internalization. So when you use cetuximab in combination with T-DXd and EGFR-rich models, you see a dramatic increase in internalization of the drug back into the tumor cells. And when you look at this in terms of clinical response, you see what looks like a kind of synergistic response. So we hope to translate this into prospective clinical trials quickly. This strategy, I think, is underutilized in existing combination trials. This is a schema of the existing combination trials for ADCs. You could see a preponderance of combination trials invoking immunotherapies or chemotherapies, but they're less using targeted therapies and less taking advantage of strategies like this. So outstanding questions. Number one, how can this strategy be applied in breast cancer? I think HER2 low breast cancer is actually a really interesting opportunity. If we were able to increase the expression of HER2 or increase the internalization in the HER2 low setting, could we make overall response rates from HER2 low breast cancer as high as they are in HER2 positive breast cancer? Second, if we acknowledge that target dynamics, not merely target expression, matters, will this open us up to discover brand new ADC targets? Is this kind of a new way to approach screening for ADC targets beyond just static expression? So in conclusion, ADCs have a complex mechanism of action. Incorporating our understanding of ADC mechanisms into rational clinical trial and biomarker design is critical. And lastly, the best is yet to come in ADC therapy for breast cancer. This is my second daughter, Hannah. She was born 9 days ago. So I'm overjoyed and underslept. So if anything in the presentation didn't make sense, this is my very proud excuse for why. Thank you very much.
Thank you, Dr. Drago, for that talk and that cute picture at the end. Next, I'd like to call Dr. Mia Levy, Chief Medical Officer of Foundation Medicine, to discuss real-world data with a focus on homologous recombination deficiencies across solid tumors.
Thank you so much to the committee for inviting me today to present in front with all of you today. I'm really excited that we talked about pan-cancer tumor indications because that is exactly what we've been working to develop at Foundation Medicine, is a homologous recombination deficiency biomarker that is across tumor types. My primary disclosure is that I am the Chief Medical Officer at Foundation Medicine, and the topic I will be discussing is directly related to that work. Biomarker discovery and development takes a traditional path from discovery, early research and development, feasibility, validation, including analytic validation and clinical validation, up to the launch of a new product. And we are in an era of real-world data that is finally allowing us to accelerate this process and leverage the strength of large data sets to really begin to understand how we can develop biomarkers across multiple cancer types. So we at Foundation have the benefit of having a very large data set upon which we can use to do this discovery work, but we really need to answer what is the unmet medical need, what is the intended use, and are those needs being met? And then finally, when we're able to show analytic and clinical validity, to be able to launch that new biomarker for research use only, investigational use only, and finally, ideally for a companion diagnostic that will help impact the selection of a drug for patient populations. To do this, we're leveraging our large clinical database of over 1 million patients who've had sequencing now with Foundation Medicine that has comprehensive molecular profiles and patient-level genomic data. This combined with a clinical data set from Flatiron, we have over 100,000 patients who have exquisitely annotated clinical outcomes as well, upon which we can then do clinical validity and clinical analytic validity studies. So why HRD? This is a relatively newer biomarker, but it's very relevant to existing drugs that are available for patients and hopefully will increase the number of patients eligible. Homologous recombination repair, HRR, is a cellular pathway that repairs double-stranded breaks in DNA, ensuring chromosomal integrity and cell viability in healthy cells, and includes key genes such as BRCA1 and 2 and PALB2, et cetera. Tumors that are deficient in HRR are referred to as homologous recombination deficient, or HRD. And mutations and loss in HRR genes are common in several cancer types, including breast, ovarian, pancreas, and prostate cancers, and these are commonly referred to as BRCA-associated cancers. HRD tumors are hypothesized to be more susceptible to DNA-damaging therapeutics through a process called synthetic lethality, confirmed through practice-changing trials with platinum chemotherapies and PARP inhibitors, as seen in ovarian cancer, HER2-negative breast cancer, pancreatic cancer, and prostate cancer. But the question is, are there other tumors that are showing the same HRD signatures for which these drugs could be available and applied, as well as new therapies such as ATR inhibitors and moving these same treatments into earlier stage disease? Upstream inactivation of BRCA or other HRR genes through methylation, biallelic mutation, or homologous loss can result in functional HRD. Tumors with HRD show characteristic DNA changes referred to as genomic scars that encompass large-scale genomic copy number changes, including telomeric allelic imbalance, loss of heterozygosity, large-scale state transitions, amongst others. In this particular example, you see an ovarian cancer sequencing tumor that has HRD positivity with biallelic BRCA loss, and you see the copy number across the genome increasing and decreasing and across the whole genome. And this is that scar we're referring to. But the landscape of HRD biomarkers is very complex. There's multiple mutational and genomic scar biomarkers that exist that can help identify tumors with HRD phenotype. Most are based on the detection of a germline or somatic mutation in one of these HRR genes. But complex scar-based biomarkers like GLOH or GIS may allow for detection of HRD in the absence of gene mutations. And this is currently approved for use in ovarian cancer only, but most of those algorithms have been trained just on ovarian cancer data sets. And so we asked the question, is there a pan-tumor HRD signature that could be developed to allow for a pan-tumor approach to this important biomarker for therapy selection? So the first thing we did is that we looked at our very large data set, close to over 1 million patients for this particular study, and we found that BRCA1 and BRCA2 mutation occurs across cancer types, including the BRCA-associated diseases, but also other common tumor types, such as non-small cell lung cancer and colorectal cancer. But not all BRCA mutations result in biallelic inactivation, and you need both copies to be altered in order to have this HRD signature and thus response to the PARP inhibitors, et cetera. So when we look at biallelic, the rate of biallelic BRC inactivation and thus prediction of association of BRCA mutation with HRD, it varies by cancer type. So it's the highest in BRCA-associated diseases. So if you have breast cancer and you have a BRCA mutation, it's most likely going to be biallelic. But if you have lung cancer and it shows a BRCA mutation in the tumor, for instance, it's about a 50% chance that it's going to be biallelic. Oftentimes, lung cancers will have very high mutation burdens, and these are really just passenger mutations, and they're not activating this HRD pathway. So in developing this pan-tumor HRD signature, we developed a machine learning algorithm that looks for scar-based copy number signatures that give this functional HRD readout in a pan-cancer approach. So we started with computable absolute copy number from shallow whole genome sequencing across the tumor, and we derived copy number features and looked at the distribution of those features, and finally fit an optimal number and a mixture into various models that resulted in an HRD signature of over 100 different copy number features together. In order to train this data set, we used a sample size of over 500,000 patients from our genomic data set. And we segmented this into true positives, those in the orange that have biallelic BRCA, and then true negative samples, those that are homologous recombination wild type, so don't have any of those known HRR genes being mutated, either monoallelic or biallelic. We then, after the development of this assay, did several analytic validation studies. Predominantly, we were looking at the concordance between our HRD signature and those patients who had BRCA biallelic loss in the BRCA-associated tumor types. But because the HRD signature isn't just based on specific HRR gene alterations, we can also detect non-genomic mechanisms of HRD, including BRCA methylation, which we're finding is to be a more and more common cause of having this HRD signature. And we do find that this HRD signature captures most biallelic BRCA as well as a subset of other HRR mutations, which you see here. You can see that there's an association with PALB2 and CDK12 and BRIP1, strongly associated with biallelic loss of those genes as well as the HRD signature. The pan-cancer rate of HRD signature in tumor samples tested using comprehensive genomic profiling during routine clinical care is 6.4%. As you can see, ovarian cancer on the far left is the most common, followed by breast cancer. Prostate and pancreatic cancer are also seen highly prevalent, but we're also seeing this HRD signature in other tumor types, such as non-small cell lung cancer and colorectal cancer. To validate the HRD signature in breast cancer as well as other tumor types, we then linked our genomic data set to that clinical outcomes database, the comprehensive CGDB database. In breast cancer specifically, HRD signature identifies patients well beyond BRCA and PALB2. So we're looking that there's a great overlap between HRD sig and biallelic BRCA and PALB2, whether it's somatic or germline. But what we're seeing is that across tumors that have had comprehensive genomic profiling, about 3.4% will have germline BRCA. This is the current companion diagnosis for PARP inhibitors in breast cancer, either in the adjuvant setting or the metastatic setting. 9.6% will have either any BRCA, meaning germline or somatic, or germline PALB2. But a whole 21% of breast cancers have this HRD signature. This is a massive increase from the current indicated uses for the PARP inhibitor drugs and could have very significant implications for our patients. Furthermore, HRD signature positivity is detected in both early and advanced breast cancers across receptor types. So on the far right, you have in the dark orange the triple negative breast cancer patients with both stage 1 through 3 and stage 4, which is the population you would expect to most see. But you also see HRD signature coming up in hormone receptor positive as well as HER2 positive breast cancers in both the early stage and advanced stage setting. When we looked at a population of patients in this retrospective data set who had PARP inhibitors with clinical outcomes, we were able to show in the orange line on the top that patients with HRD signature have a longer median real-world progression-free survival and a significantly reduced risk of progression, 6.3 versus 2.8 months on PARP inhibitors compared to patients who did not have the HRD signature detected. And we saw similar trends in real-world overall survival. Looking at other cancer types, ovarian cancer in particular, we were able to show that HRD signature was able to detect epigenetic HRD in patients with BRCA1 promoter hypermethylation. So really understanding that there's multiple mechanisms of change in these HRR genes that can lead to this signature of scarring. In the Ariel 2 clinical trial with rucaparib, we found that ovarian cancer patients had significantly improved progression-free survival in the intention to treat arm as well as in the platinum-sensitive population, and that's that upper part of the graph as well. Likewise, for maintenance PARP inhibitors, which are commonly used in ovarian cancer, we found that really only those patients in this retrospective data set, only those patients that had the HRD signature were the ones who benefited from this maintenance PARP inhibition. And those who did not have the signature on the right had no difference between PARP inhibition and nothing for maintenance therapy. Finally, we also see applicability in pancreatic cancer, and I'm not going to show the data for prostate cancer today, but we show that the HRD signature in pancreatic cancer is predictive on that far side of sensitivity and benefit to FOLFIRINOX compared to gemcitabine paclitaxel. So again, across multiple cancer types, we're seeing the potential benefit here. I'm really excited about the potential opportunities in breast cancer for the use of this biomarker. As we said, the number of patients who may potentially benefit from these medications, if you just compare the 3.4% who currently are found to have germline BRCA compared to the 21% who may have this HRD signature, it really opens up a whole new opportunity. And looking at our current standard of cares in triple-negative breast cancer, we have carboplatin, which is just this very difficult drug to add on. I don't know how many of you are using the Keynote 522, but the carboplatin just rips it up. And it's really hard. So if there was a way that we could identify those patients who may benefit from carboplatin sparing regimens, this would be a wonderful way of looking at that. And similarly, looking at in the adjuvant and first line setting for PARP inhibition, whether or not this additional patient population would benefit in this setting. So I hope I've taken you through this journey of how we develop pan-tumor biomarkers using large data sets and real-world data from clinical outcomes. It's an incredibly exciting time to finally have all of this real-world data available. And once you get your biomarker to this phase and then you're looking to do clinical utility studies to really show the benefit in a prospective randomized trial. But the ability to use real-world data in a retrospective setting can be incredibly powerful. So thank you very much for your time and attention.
Thank you, Dr. Levy. Last but not least, we have Dr. Marleen Kok, Associate Professor at Netherlands Cancer Institute, discussing identifying a biologic entity that is sensitive to immunotherapies.
Thank you so much. Good afternoon, colleagues and friends. It's a pleasure to speak to you about the developments in immunotherapy in a pan-cancer session. And waiting for my slides, I think I'm as exciting as the previous speakers, but you will see my conclusions that sometimes there's also something painful in it on things that we should do better. Okay. So these are my disclosures. So let's say you have a tumor-agnostic Olympics, with drugs competing for position number 1 and the most gold medals. I think immunotherapy will be the winner. And of course, for those that really love ADC, ADC is on the run at the back and overstepping targeted treatment. So immunotherapy currently has 66 indications, mainly in metastatic disease setting. That's massive. Most of my talk will be focusing on the early setting, because those indications, mainly in the primary, in the advanced disease setting, now you see this wave of mainly trials in the neoadjuvant setting, and that's a very exciting development. Why is neoadjuvant IO so important? I think this will be the key message of my talk. If you talk about biomarkers, this neoadjuvant setting is the way to go, because it provides a setting where you can relatively easily discover biomarkers. So if you give, on the top of this cartoon, if you first do surgery, take the tumor out, and also we take the tumor draining node out, the central node also in melanoma. I think it's key in here. And then you add your checkpoint blockade. You see in this cartoon that some T cells might be able to react to micrometastasis, while in the second line, if you give it in the neoadjuvant setting, so leave the tumor in, it's easier for the immune system to recognize the neoantigens or other antigens that can be recognized, and you have the key tumor draining node in. So in this setting, it has been shown mainly in melanoma that you have way more reactive T cells if you treat with IO in the neoadjuvant setting. In breast cancer, we don't have this direct comparison of neoadjuvant and adjuvant, but the first experiments done in mice back in 2016 was actually in a triple-negative breast cancer mouse model, showing directly that if you treat with IO when the tumor is in situ and also the lymph node is in situ, it's way more effective. I think the best clinical example is currently coming from melanoma in the very elegant SWOG 1801 trial, where patients received neoadjuvant followed by adjuvant, or in the red curve only adjuvant. You see a huge difference. So if you consider a trial for early stage breast cancer, don't start in the adjuvant setting, but give your immunotherapy in the neoadjuvant setting. Now that we have anti-PD-1 approved in numerous indications, I think there are several opportunities, massive opportunities to study biomarkers together, to study toxicity together, to study mechanism of actions. Though it also immediately raises the question, is this efficient? Consider all the trials that have been done to come to those 66 indications. We don't take into include the trials that didn't make it. Is that efficient? What if we 20 years ago would say, okay, Pembro, it will be studied in a pan-cancer fashion. Would we be on the same page? Would we have been farther? Or is this indeed the way to go? I think that's a big open question. Also, as said, a lot of enthusiasm, but there are also concerns. So the same drug, trial design looks the same, so the same concerns. I will show you a case. It's a breast cancer case, but it highlights these concerns, at least I have, and I think many of you will share with me, when you talk about immunotherapy for early stage disease. It's the case of Erin. Erin is 48. She's a colleague. She was diagnosed last autumn with triple-negative breast cancer. T2, N0, maximum diameter 2.4. It's no special type, but the pathologist reported medullary features. She started on a Keynote 522 regimen. After 3 weeks, she was like, hey, I can't find my tumor anymore. So she had several questions, which are very relevant questions, difficult to answer. For example, do I need this anthracycline portion of Keynote 522? Is there a biomarker that indeed I'm right? So is the tumor disappearing? Do I have a good triple negative? And do I need this adjuvant part of pembrolizumab? She was following San Antonio last year together with her husband. And she overheard our discussions on the possibility of de-escalation. And she dropped me an email with those questions. Of course, I couldn't answer her questions. I could only stimulate her that she asked the right questions. One thing I did was go back to your pathologist or to your physician, ask for the TILs because of these medullary features. And she did, with help of pathologist Roberto Salgado, who gave instructions to assess the TILs. TILs, 80%, which is massive. So the surface more immune cells than tumor cells. And she was right. So her MRI showed a complete response. And this summer she had her surgery, pathological complete response. By that time, she was devastated by all of the toxicities that are accompanied with the keynote 522. She was suffering for hyperthyroidism, followed by hypothyroidism, the toxicity of the chemo. She couldn't work, she couldn't drive a car, she had, brain fog, clearly. So she decided, because she was so well educated, not to take the adjuvant pembrolizumab, which was not supported by her treating team, which is of course not according to the guidelines. So this case inspired us, me, myself, and several of you are in the audience, to define those issues that we have with Keynote 522 and many other disease settings. For example, what do we know about adjuvant IO after neoadjuvant IO? I think we have to consider, not only consider, force ourselves to do a second randomization about do we need this adjuvant part. And happy to see that here in the US, the optimized PCR study from Sarah Delaney and team has just been launched. And in Europe, we are working on a similar trial, OPT-Pembro, to really study in an academic setting the value of adjuvant pembrolizumab. And then, all trials mostly use 1 year. Why 1 year? We know the story about trastuzumab that started at 1 year. And we still use 1 year. Well, everybody knows and have seen the data that for most of the patients it can be shorter. So we should together work on shorter treatment durations by including tools in trials, ctDNA, immune biomarkers, and do randomization based on those markers to see whether you can treat shorter. Chemotherapy backbone. I think there's a big question. What is still the ideal chemotherapy backbone? And that question will be, I think the next question will be on what is the ideal ADC? So the questions remain when we, improve our treatments. Biomarkers, that was the title of my topic, right? Identifying. But I think it's really a lack of biomarkers. And I think we should all, improve our treatments. Biomarkers, that was the title of my topic, right? Identifying. But I think it's really a lack of biomarkers. And I think we should all work together, not to put biomarkers as an exploratory endpoint. That's what we do. It should be as a main endpoint to prevent overtreatment and prevent the number needs to treat. And last but not least, defining high-risk patients. It's still all comers, stage 1 and 2 triple-negative breast cancer. While we all know that 1 triple-negative breast cancer is super scary. Those patients that walk in, you're like, oh gosh, she will come back with an event. While other triple negatives, for example, those with high TILs, are relatively easy to treat. For example, this story on prognostic biomarkers, why are those not in the inclusion criteria of trials? And this is just an example of breast cancer patients treated in the past without chemotherapy and TIL counts. It's triple negative all below 40. So those women where you worry. So if the TIL levels are 75% or higher, the outcome is excellent without chemotherapy. And now we treat patients with Keynote 522, so 4 chemos and pembro, while the prognosis is excellent. So I refer you to the poster on this topic that will be presented tomorrow in the poster session. Also happy to tell you that on a global level, we are trying to launch academic trials to really see whether in a prospective manner, if you have stage 1 triple negative and high TIL, whether you can really forego treatment. Then the treatment duration. I will tell you a story on developments that are ongoing at my institution. So it's really the immunotherapy neoadjuvant in melanoma. So I share my office with Christian Lang, who pioneers immunotherapy in the neoadjuvant setting. It's funny, because for him this neoadjuvant is really new. Well, for breast cancer, of course, we use it for 20 years. But of course, those discussions are relevant, because he started with immunotherapy for only 4 weeks, or 6 weeks. And we did trials in bladder cancer, colorectal cancer, and now we do it in breast cancer. Very short treatment duration. And we presented last ESMO some of the data from the Bellini trial, so in breast cancer. So if you take triple-negative breast cancer patients with at least a bit of TIL, 5%, and you treat with 4 weeks of anti-PD-1, you can see on MRI some patients really have a clinical meaningful response. So maybe those women don't need this 1 year of treatment. Biomarkers. I think I can tell the whole day on biomarkers and immunotherapy pan-cancer. Just some examples. I think this is a key paper. Over 1,000 patients, pan-cancer, all advanced disease and genomics data coming from the lab of Charlie Swanton. What they defined is not only TMB, which is improved with the clonal mutations, so clonal TMB is key, together with key cytokines like CXCL9 and CXCL13. So what we're currently doing at the NKI, because we love this neoadjuvant immunotherapy, we basically do the same experiment, but then for early stage of disease. So pooling all the data sets we have in-house that have been treated with mainly NIVO and EP. And this is what it looks like. First, principal component analysis. You see in red and in pink that bladder and colorectal look more similar towards melanoma and breast cancer. So those very global patterns, I think it's important to understand. Which gene signatures can predict in a pan-cancer fashion? We find the usual suspect Th1 signatures, tertiary lymphoid structures, etc. Also important, does context matter? Yes, of course. So here you see big differences how a biomarker can act in relation to tumor type. Another story that comes from our institution is about circulating biomarkers, so circulating eosinophils. It started actually in a breast cancer mouse model where we discovered a mechanism that we stimulate with checkpoint blockades, we stimulate CD4, IL-5 production, and we get a massive upregulation of eosinophils. In advanced triple-negative breast cancer, as you see here at the bottom, the eosinophils go up in patients that respond to checkpoint blockade. We looked at other tumor types. We see the same pattern in lung cancer, while in MSI colorectal cancer, this was not significant. And we later confirmed this in MSI cancers in the neoadjuvant setting. So maybe for MSI cancer, this increase in eosinophils is not necessary because the tumor is already so immunogenic. And lately, colleagues from Italy confirmed our findings in lung cancer, that eosinophils upregulated during treatment is key. We've seen all kinds of these figures, like cancer immunograms, so this is 7 years ago. You take TMB, you take PD-L1, some circulating biomarkers, you have an algorithm, and job is done. Though I think now 7 years later, yes, we have a lot of data, as illustrated here. So many, many biomarkers. So if you see a black circle, there's also data in breast cancer. Though the truth is, we only have 2, or maybe depending on how strict you are in the definition, 4 approved. So we have TMB, MSI, and PD-L1. So that's kind of disappointing, right? Giving all this academic research. Last but not least, so I've showed you a algorithm, but I think the literature on artificial intelligence and predicting the likelihood for an individual patient to respond to immunotherapy, I think that will be the next wave of AI-based biomarkers. And these two review present like several approaches on how this can add to existing knowledge. So in conclusion, related to biomarkers, we need biomarkers from registrational trials. You see registrational trials, lack of biomarkers, and then us, translational researchers, working very hard on biomarkers. Those worlds should come together. Guideline committees should also, take into account biomarkers that come from different trials. Because a good biomarker will lower the number needed to treat, will lower the patients that have unnecessary toxicity, and will lower financial toxicity. And this quote, it's in my thesis back in 2008 from Lajos Pustai. I think it's a very good one. Reporting significant associations between a biomarker and outcome doesn't make a test, it only makes a manuscript. Neoadjuvant immunotherapy is the way to go because it gives you the opportunity to monitor response, to think about escalation and de-escalation, because in the neoadjuvant setting you have only one chance to reach your PCR. And there is a massive need on studying effective treatment duration, which will again save toxicity and financial toxicity. Most important, there's a role in this for everyone, for pharma, regulatory bodies, guideline committees, and academics. We should do this together to make sure that this over-treatment by wonderful drugs will be less in the near future. Thanks for your attention.
Thank you to the panel for really a stimulating set of talks, giving an overview of the new era of personalized medicine that we've entered where we're not restricted, to our location in terms of cancer type, but can really match the perfect patient and cancer to the optimal therapies based on a more comprehensive molecular and immune characterization. If there's a pressing question, we may be able to take one or two, but I did want to ask one question before we concluded. A lot of what we've been discussing comes down to the biomarkers in determining what's the optimal treatment to select. So a question for the panel and food for thought is, what is the frequency in which we should be really sampling tumor tissue to pick the treatments that we want to put patients on with the existing therapies and emerging ones that are coming out? And especially with dynamic markers, the immune microenvironment we know changes with every treatment we give it, and our group and others have shown that on-treatment biomarker after starting a treatment may be actually much more predictive of response than just the baseline status of the immune microenvironment. Curious what your all thoughts are, both from a molecular and immune standpoint.
Again, here I like stories. This is a story of the six blind scientists and the elephant, right? Each of us, I just spoke about genomics, right? So if you think about the story of six blind scientists and the elephant, gender balanced, think about genomics as the tusk, metabolomics as the tail, immunogenomics or markers as the trunk, and beyond, right? We have microbiomics, proteomics and beyond. So we still don't have every bit of information for the generic patient sitting right in front of us. We do practice what we call as shallow medicine. We need deep personalized medicine for every patient walking in the door. Again, the thing is that we are still on the nascency of the field. I think it's great. And the second question is on treatment, right? It's a continuum. I think we need to sequence patients' tumors with a comprehensive molecular portrait throughout the continuum of treatment, not just at diagnosis, on treatment, post-treatment. Again, to learn about the tumor biology, what the drug does to the cancer, what the cancer cells evolve. Again, treating cancer is like the story of Hercules and the 9-headed hydra. Hercules cuts off one head of the hydra, 2 heads pop up. That's what we see in oncology. When we treat with one drug, we have 2 mechanism resistance. When we hit that, we get 2 other mechanism resistance. So how can we outwit the hydra that is cancer? That's for us to work the next decade.
Completely agree, and I think really requires collaboration between academia, the community, industry, regulatory bodies to make that happen.
Hi, John Benson from Cambridge. Thank you for an excellent, inspiring session. I just wanted to ask Marleen Kok.
We're having trouble hearing you through the microphone at the front, sorry.
So can you hear me now?
Better.
Can you hear me now? Okay, so I'm John Benson from Cambridge. I have a question for Marleen Kok. You're obviously very conscious about sort of over-treatment and side effects of treatment, particularly relating to biological therapies. Can I just ask you a practical question at the moment? How you incorporate PARP inhibitors as adjuvant treatment in patients who follow a Keynote 522 pathway but happen to be have germline mutations of BRCA1 or BRCA2. How do you kind of sequence olaparib with continuing immunotherapy? And if the patient had an excellent response, to induction chemotherapy with immunotherapy, would you omit any further pembro and just give olaparib?
So the question is on how would you incorporate PARP inhibitor into the adjuvant treatment after Keynote 522, whether you have a path to CR or not?
Yeah, so I think it's a very relevant question, and we have a lack of data, right? That in Keynote 522 there was no olaparib given, giving the timelines of the study, and also the same was for the Olympia study. So I had a big discussion on this in my institution, and we prefer in patients with a germline BRCA1 and 2 mutation, we prefer olaparib over capecitabine at least, because the level of evidence for olaparib in that population is bigger, given the number that were included in the trial. And then for most of the cases, if we had access to pembrolizumab, which is still not the case in the Netherlands, we would add pembro for most of the cases. But I think data is lacking, and also the question is whether there will be data on this topic, given the efforts that will be needed for such a trial. So thanks for the relevant question.
Thank you.
And we have safety data in the metastatic setting on the combination, so I think it's just varying practice. I combine them when I treat, given the safety that exists, whether that's superior to sequencing or not, unknown, but.
Hi, so this is Jyoti Bajpai from Mumbai, India, Tata Memorial Center. Wonderful session again and excellent talks. My question is regarding doing, in a practical real world scenario, about doing next generation sequencing. So do you prefer to do a extended gene panel for all patients, metastatic breast cancer I'm talking, or versus doing a focused panel? Because whatever said and done, generally there are a few tameable targets where the really drugs available and we can do something. So what is your thoughts?
So I'll give my personal opinion here. Again, every patient with cancer deserves a comprehensive diagnosis. Why do I say that? If we have single gene or focus 1 or 2 panels, we won't know what the mutation harbors. Think about these biomarkers like NTRK, RET, ROS1, ALK. They are seen in different tumor types. Cancers don't follow textbooks, right? So we need to have a comprehensive panel for every patient walking in the door. Even if we don't have drugs for treating that particular biomarker today, doesn't mean that there won't be a biomarker developed tomorrow. Again, genomics, my personal opinion, it should be for diagnosis as well. Because most of us think that genomics is done only to match them to therapies. No, it is prognostic, it is predictive, it is diagnostic. Beyond that, if we do start doing germline testing for all patients, it won't be just for that patient, it will be for that patient's family member and their family members as well. So again, broad-based genomic profiling, genomics for all.
Thank you.
Again, any one of the panelists can take that question as well.
We disagree with him. Just kidding. All right. Oh, sorry. Another question?
Dr. Kok, I really applaud your efforts in trying to de-escalate treatment for patients, especially on long-term immunotherapy. I had a similar patient as yours where she's a young premenopausal patient with 2 young kids. She had a really big tumor and had a PAT CR after the Keynote 522 neoadjuvant treatment. She was really reluctant to continue the immunotherapy, but also did not want to risk the chance of recurrence. So she requested for a ctDNA. This is completely off trial. So we did a ctDNA, it was positive. So we continued the adjuvant immuno, and then it became negative. So we continued for a few more months, and at that point she was comfortable to hold the treatment. So this is kind of off the, it's not standard of care, but I just wanted to ask you if you have used ctDNA in de-escalating patients on immunotherapy.
Yeah, so giving the time for my talk, I didn't have time to discuss ctDNA, but you see, across tumor types that the utility of ctDNA is there, especially if you have this neoadjuvant followed by adjuvant approach. I think the data in bladder cancer are beautiful, showing that in the ctDNA positive group, there is the benefit of checkpoint blockade. So at least in Europe, it's not standard of practice, but I wouldn't be surprised if, as long as we incorporate it in a right manner in trials, that we can really make, base decision on it. That even, especially for those that you still have some tumor left, and if that's controlled by the immune system, but if your ctDNA is gone, that might be a population where you don't need adjuvant treatment, if confirmed, of course, in future trials. So thanks for the very relevant question.
All right. I don't see anyone else standing up for a question. So thank you, everyone, for your attention. Thank you to the speakers, and enjoy the rest of the conference.